21 to 65 years old and you have a uterus that hasn't been removed by hysterectomy, you definitely should be screened, especially if you've never been screened by any GYN in the past 5 years. Now, after that initial one, you're 21 to 29 years, you have a pap test, which just looks for the abnormal cells every 3 years. Now, if you have a positive test, co-testing is strongly recommended. Every 5 years is preferred. You will be examined every year, but every 5 years is preferred if your HPV test is negative. However, if your HPV test is positive for 16 or 18, then the testing tends to be more aggressive. And then you would have to have colposcopy also done. Colposcopy is done just like you go for a pap test, but then your doctor looks with a microscope to identify the abnormal areas of the cervix. And at the same time, also a biopsy can be done. So these are the various risk factors, and these are the various stages. If you have a cervical intraepithelial neoplasia, which is a CIN, and the grade is a 3 or higher, depending on your risk, you are seen on a more frequent basis. So if your risk is less than 4%, then you're seen every 5 years, especially if you have a negative HPV test. If you have a positive HPV test and you have invasive disease, then you need to have colposcopy and excision biopsy, okay? I'm not going to go into details of cervical cancer treatment because we're talking about prevention. So this is my short and skinny on cervical cancer screening. And if you have any questions, I'm happy to take those.
Wow. As an Ashanti man once told me, Obi nyane Dr. Kwa. Thank you very much, Dr. Lydia. That was a very straightforward, direct message on cervical cancer or cervical cancer. Now, before I ask any question, I just want to comment quickly that our sister stressed on the screening, okay? Because if you're afraid of something and you're afraid of it, that's it. But she is trying to advise us on the need to take the necessary steps other than just talk about it. So thank you very much, Lydia, again. I don't have a question in the chat so far, but I have just one quick question. I've heard of the word pap smear, and is that the same as the pap test, please?
Yes, it's the
For
same
those
thing.
of the guys, that's
Pap
all
is
we
a
know.
short word for Papa Nicola, and that's the same thing. So you, just like I showed you the picture, most women think that it's a very painful procedure, but it's actually not. You just need a kind and a compassionate GYN. It's a metal speculum or a plastic speculum that is inserted when the moms lie in a position just as they're about to have a baby. That's the lithotomy position. And the speculum needs to be warmed. And once it's warmed and opened, then the GYN goes in and scrapes the cells from the surface. It's either a brush or the blunt blade. And then those cells are put in a medium in a container and it's sent to the lab and it's looked at under the microscope. And then you know whether the test results are normal or abnormal. The HPV test actually identifies the exact HPV that is causing an infection if there's a concern for that.
So I know you did mention a little bit about the use of contraceptives or lack of, I'm not a doctor, so pardon me when I use the wrong words, but the use of birth control pills, as it were. I know you don't know the reason why, but is there a way one can detect from oneself that, well, I've been taking this pill over a time and these are the changes to notice and watch out for and know that it could pose a potential problem?
Birth control pills are either prescribed by the primary care doctor or by the GYN. Most times they always have a follow-up, monitoring for side effects, monitoring for efficiency. I don't know if people just go to the pharmacy to buy birth control pills in other areas, you know, yours truly, where you don't need a prescription. So if you're doing something like that, then you decide yourself to see a GYN. But if it's under somebody who is monitoring and watching and following up, then it's also part of the routine that you will get your pap smear starting at 21 years of age. You need a genital exam. And so then it can easily be identified. But if you don't follow up, like most people think I'm fine, I don't need to see anybody. But if you have any of the signs and symptoms I mentioned, it's certainly worth benefits going to get checked.
Thank you. I know for most part we are talking of cervical cancer. We mentioned the HPV, human papilloma virus, I believe it is. Would you say that the main area that this disease attacks first, is it the mouth or is it usually in the genital area? Which is the most prevalent place that you usually find this disease,
Most
the
prevalent is the
virus?
genital. Most prevalent is the genital area, the cervix, the vulva, the vagina. Cervical cancer is the highest. It's the second most common after breast cancer for women in the low-income countries. And it's the cervix, it's the vaginal area. Now, with an increase in anal sex, you can have perianal warts or anal warts also. And then oral cancers, mostly there's also an associated risk of immunosuppression, either by HIV or through those who smoke also. So it's a whole lot of other factors that come in, but mainly cervical, vaginal, penile cancers also, and then anal cancers.
Okay. Now, along the same lines and a little bit more, probably, I know the ladies take good care of themselves, but sometimes we, the men, are a bit things. You say, for example, that a male or male partner who has had this through his throat or his oral cavity has a high risk of infecting his partner even without oral what do you call vaginal entry. I know we are adults here, but for example, if you are a man who has this in your mouth and in case your wife on the lip down there, is it possible that you you are at a high risk of transmitting the disease to her, although you have not gone down there?
So just to put it in perspective, just think of it like a cold. It's not exactly a cold, but you can get a cold several times and recover from it. Now, these infections that we're talking about are sexually transmitted. So it has to be sexually transmitted. So like I told you, the various, it's either penetrant intercourse or oral versus, vaginal intercourse. It is spread sexually. It is not spread through body fluids or just by contact.
Okay. It's very good thing that you said. Now I know for those you mentioned that most of us here probably are over the age of 30, and so the effect of the vaccine itself will be not as great as somebody who is a child. That notwithstanding, do you think it's still good that one takes it as a precaution, your personal opinion,
So
as a
based on the
precaution?
literature, I don't think it even provides more than 20% of a protection for um, prevention of cancer. And we are beginning to see, I mean, when COVID started, there was great data in 2020 on how effective the vaccine has been, because most of those who receive the vaccine, like I said, are now they are now getting into their early adulthood. So we are seeing a decrease in cervical cancer prevention that can be correlated with the vaccine. But for us, I think our biggest strategy for prevention of cancer would be regular screening, following up with our tests and our pap smears and our HPV testing. I'm sure most of us have already gone. If we haven't, this is the time to. But we have to advocate for our daughters and the younger ones so that they do get the vaccines. In my pediatric practice currently, I have a lot of patients or parents who say that I don't trust the vaccine. It's been around since 2006. So if there are any, and we are seeing the data that is moving in a positive direction. So if there are any adverse effects, we should know what the adverse effects are. The most adverse effects that I have seen is that most of the girls are so anxious about getting the vaccine that Some of them in the US, they get so nervous, they pass out after they get the vaccine. But that's like a 5-minute thing. Then they get up and say, I'm fine. And most of the time, we observe them for 15 minutes for side effects. Nobody has gotten anaphylaxis, meaning that, I can't breathe, my throat is smelling, my blood pressure is low, I need emergency admission, or I need epinephrine. No, most of them tolerate it very well. It's just like getting any other vaccine. And I just want to caution and encourage us that if you've gotten vaccines and you have seen the devastating effect of illnesses that are vaccine preventable, this is one. If there was a vaccine for cancer, I would get it anytime. And this is one of those that prevents cancer. Why not?
Thank you very much, Dr. Lydia. Let me ask, is it possible that because there is a vaccine, for example, that it could give us some false sense of security? I'm speaking not for us adults here, but especially the children. Do you think it gives them that kind of false, that they would, well, I have the vaccine, so who cares? I can do whatever. As a doctor, would you say that looking at responsible sexual behavior vis-a-vis vaccine, would you recommend that people do both aggressively, or the vaccine in itself is enough?
I don't think that it should be enough. Yes, it will give you a sense of confidence that I am protected, but it doesn't replace the basic good judgment and good decision making. Just like driving a car, you can get the best car, you can get the most expensive car, you can get in it and drive. It can give you all forms of security. But if you drive carelessly, it can be involved in an accident and you can die. So just because you have a good car, just because it works well, just because it has all the upgrades and features, doesn't replace common sense driving. So in the same way too, we make good decisions to advocate for our health. And I think that that's what we should do regardless of any vaccination. Even if you've been vaccinated, you still need to be screened. You saw that last but one slide, which says that regardless of vaccination, you still need screening. It doesn't replace it.
Thank you very much, Dr. Lydia. You used the key word I was expecting to hear, common sense.
Merci.
So I love that. Being a doctor is good. I'm trying to wind down, then we go around 3:45, we'll go to our next presenter. I can see Dr. Chi is already ready. But I am learning.
Thomas, I'm sorry to butt in, but thank you for all your wonderful questions. But a few came in the chat. I think one of them, Dr. Lydia already addressed.
Answered, yeah.
There's a question about what type of test do men get to test for the virus. I'm going to look the two questions. And the second one, does the vaccine come at a cost? And if so, how much approximately?
How much? I was going to read
If you don't mind, let me add the third one because we're trying to wrap up quickly. And the third question, they said, same question with the 1-year pap smear testing. Should we switch over to 3 to 5 years instead of yearly?
So I'm discussing the USA recommendations because this is my area of practice and geographic location. And these are the recommendations we have. Now, 1-year pap testing can be done if your pap smear is positive. Previously, we were doing a yearly, and after 3 negative, then you switch to 3 to 5 year testing. So I can only speak for my geographic location, but I think that is the best answer through a GYN. And then the next question about the vaccination too. I'm so sorry, I'm not too knowledgeable about how it is paid for without insurance. But as far as your insurance covers it, you're fine. And then there are programs here that allow you to get it through the health department. I do know that in Ghana, there are 2 vaccines also, and you pay for it. I hear the cost is, before it used to be like 400 or 800 Ghana cedis, but now it's like 1,000 or 2,000 Ghana cedis. But I always say that if you can pay to prevent cancer, then you can, and you can avoid it. Don't put cost on it because cancer treatment is very expensive. And
thank you very much.
Third question, I'm not sure if I answered the third question or not.
You did answer that when you were giving, yeah.
Yeah.
I think Thomas asked a question which addressed that.
Yeah.
Thank you.
Okay, so I think we'll take the last question and then we can go on to Dr. Chia at this point. So there has been a situation where a lot of girls, especially around the age of 10 to 13, are showing a lot of autoinflammatory, autoimmune diseases, especially in parts of the United States. And most of them seem to happen as of the time when they take a vaccine. Somehow that's when it starts showing itself. Is that an observation you have personally made? And should there be any concerns, if any, with this particular HPV vaccine? Because again, the main target here is girls, and at that age within which this supposed auto-inflammatory, I think they call it CRMO, CMO, all those OOs, if you could elaborate a bit on that, if that's a concern at all for this vaccine.
Not that I'm aware of, but there's a lot of data out there that is not true data that even links vaccine to autism. It links vaccines to, lower quantities of mercury and arsenic. It links vaccines to all kinds of things. The only data I'm aware of is the risk of getting Guillain-Barré syndrome, which is an ascending paralysis illness. That's the only one. And it's very rare. So that's all I'm aware of. I'm not too sure about other autoinflammatory conditions associated with this vaccination. But I'm happy to review the data. And if there's something out there, I'll be happy to forward it to everyone.
Good. Thank you, Dr. Lydia. We really appreciate the time with us. I will humbly plead with you. That's your summary on the screening, ages and stuff. If you could share it with the executives for public distribution so that after this, at least we have that piece in our mind to carry on with it.
Yes.
So
thank you for the opportunity. I appreciate it.
Thank you again, Dr. Lydia. We're going to go over now to Dr. Makofiche. And Doctor is a hematologist, oncologist with interest in gastrointestinal malignancies. He has been a staff physician and member of the teaching staff of the Cleveland Lerner College of Medicine. And he is here today to give us some exposition on colon cancer, which some people call old white man's disease. So Dr. Che, can you take us through your presentation or your expose on colon cancer?
I'm going to be talking about colorectal cancer and the disparities and how to mitigate it. So basically my talk will encompass talk about colon cancer rates and diagnosis. But I know that this talk is basically focused mainly on prevention. But I just put my slides together. So it's going to be a little bit extensive. Again, most of the data that I'm going to be sharing will be related to United States data because this is where, again, I live. But I'll try as much as possible to correlate it with the rest of the world because honestly, there's not much difference. And I'll go into detail as I keep on. So, colorectal cancer basically is the cancer of the colon. And what is the colon? I've put a picture up here for us to see where the colon starts. So this is where the colon starts, around the septum, all the way to the rectum. So we have the ascending colon, transverse, descending sigmoid, and rectum. So when we talk about colon and rectal cancer, because both of them are treated together, they are addressed together. They are not treated the same way, but they are bunched up together. So colorectal cancers affect the large bowel. And this is how the large bowel looks like. So the anus is not part of the large bowel. Appendix is not part of the large bowel. All right, so what's cancer as a whole? So basically, cancer is a disease that affects some cells in the body and makes them abnormal, and they begin to grow uncontrollably and spread to other parts of the body. Basically, cancer is a genetic disease. Why do I say so? Because there are certain mutations that happen in your genetic makeup, your DNA. And these genes basically control the behavior and function of cells. So basically, if you develop an abnormality in that gene, which is called a mutation, it makes the cancer behave abnormal, uncontrollably. And it makes it grow, as we can see on the diagram that I put up here. So the cancer cells do not only increase in number, but they are also abnormal in their behavior and their shape. So causes of cancer, I mean, as I said, cancer is a genetic disease. There are so many things that may cause genetic abnormalities in a cell. So when you have a DNA damage, and that can be caused by smoking, tobacco smoking, UV rays, certain chemicals, such as organic solvents and ionizing radiation. You can develop these mutations and they put you at risk for developing cancer. As a result of that, these errors they happen in the cells as they divide. Normally, God in his own wisdom has given us ways to correct these errors as they happen. Anytime you have cell division, the potential of making errors in your DNA is high. It can happen. But the body is a high fidelity system. It corrects the mistakes. And the mistakes that cannot be corrected, the cell dies. So we have what we call programmed cell death. I mean, Dr. Lydia mentioned that before. Scientifically, we call it apoptosis. So these process of programmed cell death, the cell dying, is also controlled by a gene. So if that gene is also affected with a mutation, the cell will not die and basically persist. So I'm not going to bore you with this slide. This is a little bit scientific, but I just want to share with you some theory behind cancer development. So there's this cancer stem cell theory, where it's believed that the cell basically develops one of those mutations that I just mentioned, and confers a certain property to that cell, where it begins to behave just like a stem cell. Now, stem cells are very rare and few cells in our body that basically generates almost all the cells that are present in our body. They have certain peculiar characteristics. They have self-regeneration or self-renewal. They continue to multiply, but they rarely basically multiply. When the need arises, they will multiply. They never die. So these are stem cells in our body. It's very hard to find them. I mean, you have to probe very hard, especially for blood. I mean, you do a bone marrow, you have to really look before you can identify a stem cell. Now, if there is any somatic cell, meaning any outside cell other than the stem cell, develops a mutation, and then that mutation gives it a property or a behavior that is similar to the stem cell, then it begins to become a cancer cell. Basically, that's how cancer cells begin. They uncontrollably divide. And it's like there is one particular cell that is basically multiplying all the time. And it gets to a point where when the stem cell divides, makes itself to basically replaces its population, and then the rest will grow, they will differentiate into other cells of the area that they are affecting. Then they become the cancer cells that we see and identify. Now, this theory that I'm sharing with you is because sometimes we give chemotherapy, we kill the cells that are around the stem cell, and then the tumor shrinks, but later on it grows back again because the stem cell is still there, which will repopulate the cancer cells. But if you're able to identify a treatment that can target the stem cell, it will just kill the stem cell, and the rest of the cells will also die off, and the tumor will regress and not recur. Anyway, this is a side issue. So, colon cancer sequence. This slide is very, very important. Basically, I'm trying to talk about background, what cancers are, the biology behind cancers in general. And now I'm talking about colon cancer. This slide I'm going to share again later with you. Now, colon cancer doesn't just happen out of thin air, and it doesn't just happen out of the blue. Almost all colon cancers, about 90% of them, will develop out of a polyp. So there are certain events that happen, and these events that I talk about are the genetic mutations that I'm talking about. So you have a normal lining of a colon, a normal colon epithelium or lining. Then with time, you may develop a mutation, which could be one of these, APC, beta-catenin mutations. And then this leads to a polyp formation. Now, this polyp, when you develop this polyp, you develop more mutations as time goes on. And it moves on from just a benign hyperplastic polyp to an adenoma, and then adenocarcinoma, and then a mutation that will make it more invasive and spread out. This process takes at least about 3 to 5 years. I mean, over here it says 5 to 20 years. In some cases, that's how it is. This is a very important information that I want to share. And this will come in play why screening for colon cancer is very, very important. Because colon cancer doesn't just happen out of the blue. So if you get your screening on schedule, you will be able to prevent colon cancer. At least if you have something abnormal, a polyp that is present, that can be removed so that you don't give it a chance for it to spread out. So, colorectal cancer incidence, and this is where I say that I'm sharing most of my data is related to United States. It is the second most deadliest cancer in both men and women, only after lung cancer. The rate of colon cancer varies among race, ethnic groups, and even sex. Minority groups are disproportionately affected, especially Black communities. And I'm going to elaborate a little bit further as we go. And also, the age of incidence is decreasing. It used to be that, we all thought that colon cancer, the older you get, the chances you get it. And most of the time we thought that age 50 and above, that's where the incidence happen. Yes, I mean, majority of colon cancers happen after age 50. But we are seeing that the age of incidence is actually decreasing, and the rate of incidence of colon cancer in those who are young, and when I say young, meaning that under age 50, is increasing. So this has prompted us and in the scientific community, as well as the US Preventative Task Force, to change guidelines. So the screening for colon cancer has started earlier than it used to be before. And African Americans also have worse outcomes and tend to have aggressive disease. So in 2023, it's estimated that over 153,000 cases, new cases, will be diagnosed. Now, just over 52,000 deaths will occur in the United States. And over 19,000 new cases will be diagnosed in younger individuals, those who are under age 50. And 3,700 cases of death in this group. The rate, again, as I said, is increasing, and the incidence is about 2% per year in young individuals, as well as death is about 1% per year. Black folks have about 41.7 per 100,000 population incidents. So these are the group that we think that they are being disproportionately affected. There's disparity in that group because we focused mainly on those who are 50 and older. And now we are changing our recommendations and practices. African Americans have about 20% more likely chance of having colorectal cancer and 40% more likely chance of dying from their disease. So if we look at the CDC rates here, we can see colorectal cancer. This is all race and ethnic groups. This is the incidence per 100,000. But if you break it down per according to race and ethnicity, the most common race, the highest incidence happen in Alaskan Indians and Natives. Oh, let me go back, sorry. Alaskan Indians and Natives, followed by Blacks, non-Hispanic Blacks. Then we have non-Hispanic whites, and then Hispanics and the Asian community. So the Asians are the ones that tend to have the least incidents. And I have this picture to show you young individuals who had colon cancer, and some basically, we know Chadwick died from colon cancer. So do not think that, oh, I'm young and so I cannot have colon cancer. These were individuals in their 40s, 30s and 40s who had colon cancer. So the risk of developing colorectal cancer, again, age. I mentioned that majority of cases of colorectal cancer, 90% of them will happen after age 90, but the incidence is increasing in those who are younger. Family history. If you have a positive family history of colon cancer, especially a first-degree relative or several members, and especially someone who had it at a younger age, less than 50, that increases your risk. A personal history or family history of polyps. This is very, very important. Remember that colorectal cancer sequence that I showed? Polyps. So if you know someone in your family with polyps, you also have to get screened. Personal history of colorectal cancer or other cancers like breast cancer, uterine cancer, ovarian cancer. There are certain cancers that are genetic. Basically, we call them familial cancer syndromes. They come along with colon cancer. If you develop a type of cancer, it increases your risk of developing colon cancer. And I'll talk a little bit about that. Cigarette smoking, excess alcohol, obesity has been known to be a risk factor for colon cancer, and lack of exercise. Dietary habits, high fat diet, red meat, low calcium, low folate, low fiber diets. These also are risk factors for increased risk of colorectal cancer. I've also listed here some racial and ethnic disparities, certain factors. The same factors that I've mentioned earlier on the previous slides also happen in minority individuals. But in addition to that, there are also social determinants of health. And Dr. Lydia mentioned about that in her presentation. It also happens in all other cancers, including colorectal cancers. So poverty, lack of education, lack of transportation, healthcare access and screenings. Food, I mentioned about food earlier on. If you eat junk food, your risk of developing colorectal cancer increases. And race and bias. Yeah, that just by biases also increases our risk, because there are certain things that will be offered, or certain educational information that will be offered to certain community, or when a person presents to the healthcare facility because of biases, certain recommendations may not be recommended or offered to that person. So what are the symptoms of colorectal cancer? So bleeding is number one. Colon cancer always bleeds. So you may end up having blood in the stools or black stools. And there will be a change in your bowel habit, mostly constipation. You can have alternating constipation and diarrhea. The change in your stool caliber becomes thin and pencil-shaped. You tend to spend more time in the bathroom than usual. Again, if you bleed, you become anemic. I always tell my patients that when someone is a male or a postmenopausal female woman comes to me and has iron deficiency, you will always think of bleeding. And the most common source of blood loss is the gut. So you will get screened, you get scoped to try and figure out where this blood loss is coming from. And you won't believe me that the number of people that have picked up having colon cancers, just simply because they come to me for iron deficiency, especially in males who are 50 and above. Again, shortness of breath, unintentional weight loss, and loss of appetite. These are the additional symptoms that you get. And I put this there, as you get old, your wishes changes. And this gentleman is telling Santa to give him a regular bowel habit. So, diagnosis of colon cancer. First of all, we do blood work. There is a caveat here. Actually, there's no blood test to diagnose colon cancer. But these blood tests give you an idea. I mentioned earlier on anemia, iron deficiency. That will give you a trigger, in your mind to always think of, hey, what's going on in the gut? Then there's a tumor marker called CEA. We check for that, and sometimes it's elevated. Most of the time it's elevated, but it's so non-specific and unreliable. So we don't focus on that. Basically, it becomes relevant after you've made a diagnosis of colon cancer. Imaging studies. So we do X-rays and CT scans. CT scans are much better. And in certain cases, you do an MRI or PET scan of the abdomen. I mean, PET scan is a whole body scan. MRI of the abdomen, we do that, and CT scans as well. And you may see a mass in the colon. If it's spread out, you may see a mass in the liver as well. But the definitive procedure to make a diagnosis of colorectal cancer is colonoscopy. And I'll talk a little bit about that, go into detail what a colonoscopy is. Basically, it's a tube, a flexible hose or tube with a light at the end. And we go through the bowel and look. And that is what we see a mass sitting there. And then you get a biopsy. So you get a biopsy, you take it to the lab, the pathologist looks at it and makes a diagnosis of colon cancer. So we do have different stages of colon cancer. So it ranges from stage 0 to stage 4. Stage 0 is a non-invasive cancer. Basically, is restricted to the lining of the bowel. You see here, can you see my cursor? So it says mucosa, that's the lining. So if you have a tumor restricted here, that's a stage 0. It's a non-invasive cancer. Basically, it's also known as carcinoma in situ. Then when it starts going down into the submucosa, here it becomes a stage 1. Here it hasn't gone all the way into the muscle layer. When it gets into the muscle layer, it becomes a stage 2. It hasn't gone all the way across and involving lymph nodes. So extending into the muscle layer all the way to the surface, but no lymph nodes involvement is a stage 2. When you have anywhere from the submucosa all the way to the surface, but in addition to that, you have lymph nodes involved, that becomes a stage 3. And then stage 4 is where it spreads out to other organs. Now, why is this important? Why is staging important? Staging is important because it has an impact on your survival. You know, overall, 5 years, if you have colorectal cancer, you have a 63% chance of surviving 5 years. If you have a stage 3, your 5-year survival is about 73%. However, this number drops significantly if you have a stage 4. You only have a 17% chance of survival. Now, how do you treat colon cancer? Depending on your stage. If you have it only in the mucosa, like the stage 0 or stage 1, stage 0, if it's only restricted to the polyp, you just remove the polyp, so polypectomy. If it's a more invasive, you do a partial colectomy, your surgeon removes a part of your colon and can hook it back up, connect it back. However, if it's such that we can't connect it, you get a colostomy. That is like a bag, a diversion. Yeah. And then we also have radiofrequency ablation with the heat destroying the cells. These are also, this is a modality that is used mainly in stage 1 or stage 0 stages. And then we have radiation, and then we have chemotherapy. Chemotherapy is usually recommended or advised or suggested for those who have locally advanced disease or advanced disease like stage 3 and stage 4. Now, this is the meat of my presentation. I know I spent quite a bit of time, but this is important. So prevention of colon cancer. And you realize that most of the things that were mentioned earlier on also applies here. So number one, avoid smoking, because smoking is a risk. Alcohol consumption. I mean, it used to be that we used to say moderate alcohol consumption. But now we know, even in recently New England Journal of Medicine, there is a study that was published saying that there's no good alcohol. Even a tinge of alcohol is still not good. It has a damage to your body. Anyways, I'm not going to elaborate too much on that. Exercise and maintaining a good, healthy weight. Very, very important. Healthy dietary habits. Less red meat, less fat, less high caloric diet, more vegetables. You have to know your family history and keep track of it. If you know that you have a family history, especially of somebody who had colon cancer or polyps at a young age, you take measures to get yourself screened and be up to date with your screening tests and recommended guidelines. So you see, broccoli is one of the vegetables that most people recommend to reduce your risk of colon cancer. Yeah. So why is screening so important for colon cancer? It's because colorectal cancer is preventable. Unlike cervical cancer, where you have a vaccine, we don't have a vaccine, but we do have a modality that can prevent you from having colon cancer, because the nature of the disease itself tends itself to be prevented. Nearly almost all colorectal cancers happen in the polyp. And you remember that sequence that I showed you? I'm going to show you again. It takes a longer time for cancer to develop from the polyp stage to the cancer stage. So if you get screened and you remove your polyp, you prevent the cancer from happening. So that's why these slides come back again. Here, you have a normal mucosa or colon, an incipient polyp, adenoma. Then it becomes an advanced adenoma depending on the mutations that happen, and then you develop cancer. If you remove this from here, you don't develop this one. All right, so colon cancer screening. Screening now, as we speak, starts at age 45. It used to be 50, it's now 45. So anybody here who is listening, or you know a family member who is 45 years or older, should have screening for colon cancer. If you have a family member who has had colorectal cancer, especially at an earlier age 50 or less, you should get screened earlier. Actually, we say that you should get screened 10 years earlier than the age at which that family member was diagnosed. So assuming that member was diagnosed at age 40, you get screened at age 30. Now, screening modalities. The standard or the gold standard is colonoscopy. I mean, we do have other tests, but the gold standard is colonoscopy. And the colonoscopy, you go through the colon. If you get your colonoscopy, your first colonoscopy, and it's pristine, normal, your next colonoscopy is 10 years. If you get a sigmoidoscopy, meaning that the sigmoidoscopy only looks through the lower part of the colon. You remember that colon diagram that I showed? It doesn't go all the way into the cecum. If I can, I don't have any. So this is the sigmoid colon. So the sigmoidoscopy only comes up to somewhere here, mid of the descending colon. All this side you do not have any access to check. If you have a sigmoidoscopy, you repeat every 3 to 5 years. If you get a colonoscopy, which looks all the way here into and even into the terminal ileum, this last part of the small bowel, and is normal, you repeat every 10 years. So the gold standard is the colonoscopy. So that is what I would recommend. For those who are at low risk for colon cancer, maybe a young person, 45, never had a family history of colon cancer or polyps, healthy, you can do a fecal occult stool test. Basically, this is a card that they give to you. You take at home, you take a stool sample, put it on, ship it in, and we look for any blood, occult blood that your eyes cannot see. The FIT test, the fecal immunotest, is similar to all the fecal occult blood test, but it's more sensitive because we also look for blood that cannot be detected, but it is more sensitive. Is a little bit technical for that. Now, we also look for fecal DNA test. The DNA is also to look for blood, and also now we do have cancer DNA that sometimes we detect. And some tests look for these cancer signature DNAs. So that's also a screening test that can be done. Cologuard, I believe you guys have heard of Cologuard. So this is a box that is shipped to you by a company that does the Cologuard. Your primary physician orders that and they ship it to you. And you have to take a full bow and crap into it. Excuse me for my French. Yeah. It's not like, oh, you take a small sample. No, this is a full stool sample that you submit, and then they test. And if they find blood or any DNA, anything that's suggestive that, okay, there's something abnormal in your bowel, then you get a colonoscopy. And then we have the CT colonography, which is a CT scan, which basically puts together a 3D rendering of your colon. And if there's a polyp or any abnormal thing in there, we look further. Now, you can see that all these other tests, if they become abnormal, the next thing you get is what? A colonoscopy. You see that? So the colonoscopy eventually is what will look into the bowel and tell us exactly what's going on in the bowel, whether it's a polyp or it's a cancer. So that's why it is the gold standard. So if you can get a colonoscopy, please do that. There's a lot of misconception about colonoscopy. Oh, it's so painful. It's so uncomfortable. And people make such a big fuss about the prep, not the colonoscopy itself, but the preparation. I don't know why. Is it because you have to move your bowel several times? But anyways, different strokes for different folks. But I would encourage you to consider colonoscopy if you are eligible to get screened. So now, focusing on young individuals. As I said, screening has already started at age 45, but we know our current data is that those who are 45 and older have about 59% chance of being screened. This is in 2021. But when you go and look at those who are 45 and younger, the screening incidence was only 20%. So not a lot of people are getting screened at a younger age. Again, if you have less than a high school education, your screening is only 45. If you are uninsured, 20%. If you're a recent immigrant, your chances of getting screened is only 29%. Now, assuming a person who is age 45, less than 50, high school education, none, he is uninsured, he or she is uninsured, and a recent immigrant. That is a triple whammy. That person, I'm pretty sure that will never ever get screened in their life. And that's the person who is at risk of developing colon cancer. And that's why the disparity and we need to focus and have certain programs and public health initiatives to target these individuals. Now, this is the colonoscopy that I mentioned. So basically it's a scope, a flexible scope that goes through your colon all the way, and it has a camera attached to a computer screen, and it shows your colon. And if you have a nice colon, it will show it. If you have a polyp or a cancer, it will pick it up, and then we get a biopsy. So colonoscopy is the optimal screening modality, important for all abnormal fecal occult stool tests. So if you get a stool test that is abnormal, you will need a colonoscopy, and it should be done in a timely manner. Your age of onset, 45. So if you're 45 here, you should have a colonoscopy at least once in your lifetime. If it's normal, 10 years. If it's abnormal, depending on what they find, if they find a polyp, you may have to get a repeat in 3 years' time. If it's a hyperplastic benign polyp, 3 to 5 years. If it's a dysplastic polyp that was removed, then your GI doctor or your colorectal surgeon may want to go in much sooner. Some people even get a year later to make sure that their colon is truly clean. And some people don't, again, they gripe a lot about the prep. They don't drink the prep enough, and their bowel is not clean enough. So they go in, they look, and there's all fecal material in there. You can't see much. So you have to get a repeat colonoscopy. Yeah. So please, it's just a one time in your lifetime, 10 years, you repeat. Just, I'm begging you. I can't plead enough. An increased use of fecal occult blood test or FIT test should be encouraged. These are things that we can also implement. And outreach programs, what I just mentioned, to communities that are affected, especially partnering with hospitals and churches and other programs, just like what we're doing right now, to share and educate our community so that people will take initiative and take steps to take care of themselves. Now, there are also new screening tools that I mentioned earlier on, Cologuard and CT colonographies that are non-invasive as opposed to colonoscopy. You can opt for that if you have a low risk status. So I'm begging you, it's time for your colonoscopy. All right, so I may summarize here. This is basically my last slide. The incidence of colon cancer is increasing in young individuals, even though the overall incidence in the general population is decreasing because of screening. Minority population is greatly affected and have poor outcomes. Colon cancer is preventable, and it can easily be prevented through screening. Screening for colon cancer should start at age 45 or earlier in those with positive family history. And education, and identification of risk factors. Very, very important to mitigate the disparity in young folks and minorities. And we have this walk that is raising awareness about colon cancer in the community. So anybody that lives here in Cleveland, Ohio, I encourage you to sign up and get involved. Thank you.
Thank you very much, Dr. J. We do have one question in the chat, so I'll go quickly. Question about somebody stating that they have been doing an at-home test regarding this, and they are asking the at-home and comparing it to a doctor's visit. What would you recommend?
Well, at home test, I mean, is he talking about fecal occult stool test or fit test? If
to be honest, it said I received my colonoscopy screening sent to my home, so I don't know which one.
Yeah,
would you recommend at home? Or
I think a Cologuard. I mean, that's what's sent.
Okay.
I mean, if you're a standard risk, what we call a standard risk individual, you don't have a positive family history, you don't have a history of polyps in your family, you don't have history of other cancers that put you at risk of colon cancer. There are certain cancers, pancreatic cancer, breast cancer. It's like a syndrome. They come together. There's a Lynch syndrome, and then we have polyposis syndrome. These come along with certain mutations, and these mutations increase your risk for colon cancer. If you have a family history, someone else who has had some cancer that can put you at risk for colon cancer, you do not have standard risk. So assuming you are a young person, age 45 to 50, no family history, healthy, no polyps, you can have your Cologuard as an option, which is acceptable as long as it's fine, normal, negative. It's okay, it's acceptable. Once it becomes abnormal, you bump up into getting a colonoscopy. Again, for standard risk individuals, as well as high risk individuals, the high risk are those that I've mentioned, the risk factors. You are supposed to have colonoscopy. I mean, even for standard risk people, we encourage you to have a colonoscopy. For high risk individuals, you get a colonoscopy. No two ways about that.
Thank you very much. I think somebody also had a comment about the fact that the pre-med tastes extremely awful. And is there any way one could improve its its consumption, if any?
Well, I mean, the prep, you know, we've come a long way with the prep. I mean, it used to be that it was just a plain salt and sugar liquid that you have to drink a whole gallon of it. Now they are flavored. They have pineapple, orange flavored prep that you drink. And again, there are also other preps. So we have the standard prep, which is a go lightly prep. You have to drink a whole gallon to clear your system. But that is what most of the GI folks prefer. However, there are other alternatives that come. We have what we call a movie prep. It's a small bottle that you drink. It's less than half a liter. I mean, it's a small bottle. Some people, it clears them out. Some it doesn't. That's why the GI folks don't like that as the option. And then we have the Miralax. I mean, some other combination. I don't want to use the word concoction. Combination that the GI folks also recommend, which include Maalox, Miralax, some three combination, and basically you take these pills and drink like a glass or two of water, and sometimes it clears your system and you go. these are all alternatives that you can explore with your doctor if you don't want to drink the whole gallon. The movie prep, personally, is the alternative that I tend to recommend for my patients.
Okay.
The standard is the Go Lightly. And I mean, they have flavors.
Okay. Yeah, I know we are past 1.5 hours as we promised, but this is a very informative topic. And we still do have some questions. I believe the person who talked about the in-home test was talking of an FITT.
Yeah,
I don't know what that is.
The fit
Yeah,
test.
so that's a Cologuard.
No, that's the fecal immunochemical stain test.
Oh, okay. Okay.
It's
Okay.
like the stool card is but it's a little bit more technical than the old fecal alcohol blood test. It's the same. You take a stool sample and put it on a card, and then you ship it. And
Okay.
you test for blood on it. Yeah.
So a question here. What about somebody who has a tumor removed on their pituitary gland? Is that person at risk of other cancers?
No.
And maybe let me add this question. Can the colonoscopy be done without a general anesthesia?
So colonoscopy.
So twofold. Sorry. Go ahead, okay.
First of all, pituitary, if you have a pituitary tumor that's removed, it depends on what type of pituitary tumor that was removed. Most pituitary tumors are adenomas, and they have nothing to do with colon cancers. Now, there are certain cancers that may happen in the pituitary gland. Most of the time are hormonal tumors, and they are not related, linked to colon cancers. So that's separate. Regarding the
anesthesia,
most colonoscopies are done under what we call a twilight sleep. So they use certain type of anesthesia called Versed. So it's sad that we don't completely anesthetize you. We don't knock you off. You are aware of your surroundings, but you more or less after the procedure, you don't remember much about it. So you will know. I mean, some people are alert. I mean, throughout the whole procedure, they see the screen, they look at whatever is going on. But some people, yes, it makes them doze off. Everybody is different how you can tolerate it, but it's not a general anesthesia.
Okay. So there's a question here that shows, is there any data to prove that vegetarians have a low risk because they eat more fat? Let me also add this. Let's say somebody eats a lot of garlic, a lot of ginger, turmeric, pineapple, mangoes. Does that help in any way prevent colon cancer?
Yeah, all right. That's a good question. So there are certain dietary lifestyle that actually decreases risk of colon cancer. And worldwide, I mean, there are certain population that the incidence of colon cancer is much lower. And these people are the ones that tend to eat more vegetables, than red meat. So there is data to support that. However, having said that, vegetarian lifestyle has been shown to decrease risk of colon cancer as well. I mean, I didn't mention other things for the sake of our time, like aspirin. There's data that show that aspirin reduces risk of colon cancer, but the amount of aspirin that you have to take to reduce your risk of colon cancer causes more problem. So we do not recommend it routinely. Yeah.
Okay.
Vegetables, yes, is not. Yeah. Was there a second question?
I think there was about the ginger and stuff, but it's basically the same thing.
Yeah, those we don't know.
Okay.
Much about that. Those specific peculiar.
Yeah. So, Senior, you mentioned something that was very important, and in your list, you mentioned biases, right?
Yeah.
I know something happened recently. Two colleagues at work. I'm not playing any card here. One is a white guy, one is a black guy. The black guy presents constantly to his GP saying that he kind of feels some pain in the stomach. That gives him one or two things. The other guy goes, and after a short while, the guy says, "No, I think you need a colonoscopy. Something has to be done to see what's going on." Long and short, the black guy ends up going to the emergency room one night, and they detected that he should have come earlier. But they were able to do something in the colon, and then, so it's a good point you made. I think we are the best keeper of our own bodies, right? We know our bodies, so we definitely have to make the move and take good care of ourselves.
Yes, and that's yeah. Basically, that's a great point. That's a good point. And I mean, we have implicit biases. I mean, these are subconscious biases. I mean, blacks sometimes the community thinks, oh,
Superhuman.
to tolerate pain more than white folks. So when a black person goes in complaining of pain, it gets dampened down. Meanwhile, there's a serious issue going on that should be taken care of. Yeah. And
yeah, one thing I wanted to ask, is there any connection whatsoever between GERD, ulcers, and colon cancer? And as you answer that, let me ask what may seem a bit of an idiotic question, but I'm not heavy into bio. Is there a difference between an intestine and a colon, by the way? Is it one and the same or not?
all right.
I'm just asking for me.
All right. Okay. So first of all, ulcers, GERDs, these are upper abdominal symptoms, pain. They happen mainly in your stomach and your upper, so your esophagus, lower esophagus, and stomach. Ulcer, obviously, if it happens in your stomach or the first part of your small bowel, which is the duodenum. That some ulcers, I mean, majority of ulcers are benign. I mean, peptic ulcers. But some ulcers are cancer related. So, but these are stomach cancers. So it has nothing to do with colon. So you can have a stomach cancer, and on top of it, you have an ulcer sitting there. And that the ulcer may be the presenting sign of this cancer underneath it. And then you go, you biopsy, then the cancer is under it. The GERD symptoms may also be a sign that you may have an esophageal cancer or a benign acid reflux, or something like that. So that's separate from colon cancer. But those symptoms can also be related to cancer of the upper GI, so the esophagus, the stomach, and the first part of the small bowel cancers. Now, to answer your question about intestine and colon. Colon is the large intestine. And then we have—
I'm educated.
Yeah. So if you say large bowel, that's the colon all the way down to the rectum. And that is large intestine. And
okay.
The small intestines are the small bowels, which is the duodenum, jejunum, and the ileum.
Okay. Now, I think I'll ask the last question if there's no other question in the chat. But is there any possibility of developing rectal cancer through anal sex or any anal penetration?
Not that we know of. Rectal cancers, just like colon cancers, I mean, the two are similar in terms of risk factors and genetic link. but they're treated differently because of their location. So we tend to add radiation to the treatment for rectal cancer as opposed to colon cancer. However, anal cancer is known to be associated with risk of anal sex and anal penetration. Yeah, because the same risk that happens with the cervical cancer and the oropharyngeal cancer, same also happen. Basically, they are similar. These are grouped together. The same HPV, squamous cell carcinoma, it happens in these three locations. Yeah. So the risk of anal sex increases anal cancer. But anal cancer, I told you, the anus is different from rectum. So it's not part of the colorectal.
Yeah. Okay. Thank you very much, Senior, and thank you also, Dr. Lydia. This has been very informative. I don't see any hand raised up on the Zoom. So I would assume at this point that we have exhausted all our questions. But again, I want to thank you very much for this very wonderful session. Before I hand over, there was one question that came, and I apologize. And this goes to Dr. Lydia and indeed Dr. Chia as well. What type of test do men need to get for the HPV virus? Is there a test men need to take? It looks like the men were getting away easy, so somebody had to ask that.
Yeah, I think there's a. Okay, I'll let Dr. Lydia answer it. Yeah.
Oh, okay. So there's no routine testing for men, and they are not routinely screened for HPV just because they don't have the squamocolumnar junction that I talked about as much. However, because there's an increased risk of anal to penile sex nationwide, some practices are screening men for an HPV test and literally kind of doing a pap test for men to look for the HPV, to look for abnormal cells and test them for HPV. But CDC does not routinely recommend screening for men. The only ones who are tested are those who have pure anal warts, and those lesions can be sent for biopsies and then stained and tested for HPV. But there's no screening, like with cervical cancer, the screening is mainly for those who have a cervix.
Thank you very much.
You add a little bit to it. Those who present with oral cancers, oropharyngeal cancers, we know that HPV, there are HPV associated oropharyngeal cancers. So these individuals also get tested for HPV.
Okay. So thank you both very much. Before I hand over to Lillian and to Doreen, I just have one simple, humble request. I will humbly plead with all of us to just give a minute silence to all Hobsons and APSUnians who have lost their life or have fallen as a result of cancer in general. So, ladies and gentlemen, we just want to have just a minute silence before I hand over to my sister or my sisters. May the souls of all the faithful departed Hobsons and APSUnians, through the mercy of God, rest in peace. Amen. Over to you, Lillian and Doreen.
Thomas and Sister Lillian, thank you so much. And to the doctors, thank you. Let me hand it over to the president of APSU USA. Mr. President, please close us and let's wrap up.
All right. Thank you, Sister Doreen. So I am delighted to be a part of this event. And I'm also delighted to say that our APSU-HOPSA bonding is still strong. So on behalf of the executives of HOPSA USA Canada and the executives of APSU USA, we wish to thank all those who prepared for this event, especially Dr. Lydia Boateng and Dr. Mark Che for doing such an exquisite job, giving us all these insights. And also to our wonderful MCs or moderators, Sister Lillian and Brother Thomas Ando, for handling this program so masterfully. Even though we went over time, you couldn't really feel it because we thought we had something great going on. So thank you all for that. And for those who joined, we want to say thank you for making the time. We hope that you will join more of our programs coming soon. I know there are 3 more sessions for October going on. And so we wish to see you all on these programs. And shameless plug, APSU always has North Star series, so please look out on their HOPSA, chat or platforms. You see our programs there as well. So thank you once again, and greetings to all of you.